Thanks everyone for hopping on today. Today I will be presenting hot off the press for HRS, Terlipressin use in hepatorenal syndrome. And thank you to Jeff Fish, who has served as my content expert throughout the preparation of this presentation. All right, the objectives of this presentation are to, 1, describe the pathophysiology surrounding hepatorenal syndrome, 2, identify terlipressin's place in therapy in hepatorenal syndrome, and 3, summarize concerns regarding safety of terlipressin. Jumping right into some background, hepatorenal syndrome, or HRS, is a specific type of kidney injury that occurs in advanced liver disease. It's a late complication of cirrhosis, and the kidney injury can be acute or chronic. It is specifically a pre-renal type of kidney injury, and the injury starts out as reversible, but depending on how long and how severe the HRS persists, the injury can become permanent if structural damage is done to the kidney. As you will all find out shortly, HRS is very heterogeneous in nature, and that's with respect to its overall pathophysiology and also its definition criteria. In terms of prevalence, AKI develops in up to 50% of patients with decompensated cirrhosis, and HRS-AKI accounts for up to 43% of these AKI cases. Mortality associated with HRS is estimated to be about 46%, and patients with HRS and cirrhosis have been shown to have longer length of stays and higher cost of hospitalization compared to patients with cirrhosis without HRS. When thinking about different types of AKI in patients with cirrhosis, the two most common causes are pre-renal and acute tubular necrosis, or ATN. Specifically for pre-renal, we think of either hypovolemia or HRS-AKI as the two most common causes. And then for ATN, we can suspect either shock, whether that's septic or hypovolemic shock, or nephrotoxins contributing most commonly to ATN. When thinking about the diagnosis for HRS, it can be difficult, as the diagnosis is a diagnosis of exclusion. And because many other causes of AKI can be in place, it's important to consider what other factors are contributing to AKI when trying to make this diagnosis. And since we know that kidney injury is usually multifactorial, it's important to consider all of these before making this diagnosis of exclusion. HRS occurs in the absence of hypovolemia or intrinsic kidney histology, which means we want to rule out these causes of AKI before we would consider a diagnosis of HRS. Additionally, I want to call out that the diagnosis of HRS does take into account serum creatinine. Like many other disease states, we use serum creatinine as a marker for kidney function. But specifically in patients with liver disease, this can be challenging, as serum creatinine can actually overestimate the eGFR in these patients. And that can be due to a couple different reasons. For example, these patients could have decreased creatinine production in their liver, or see different calorie wasting or calorie malnutrition, which can also lower their serum creatinine. All right, so when considering the definitions of HRS, definitions have actually evolved over time. And if you were to read up on the literature, you're going to see multiple different terms for HRS used. So this slide illustrates a big picture how those definitions have evolved. Starting with back in 2007, the International Club of Ascites, or ICA, first kind of coined this HRS overarching umbrella term. And from there, HRS was split up into type 1 or type 2 HRS. Fast forward to 2019, the ICA has kind of revised these definitions. And instead of having this additional overarching term of HRS, they've merged this into just two forms of HRS, being HRS-AKI and HRS-CKD. This slide is exactly the slide that we just saw, but with more details as to what these definitions actually mean. And I don't want to get too in the weeds here, but just at a high level, initially in 2007, HRS was defined as cirrhosis with ascites and had a serum creatinine cutoff of at least 1.5. Additionally, these patients had to have no improvement after 2 days of volume expansion and albumin. They had to have the absence of shock or parenchymal kidney disease, and also could not have recent nephrotoxins. From here, HRS was split into type 1 versus type 2. Type 1 representing 100% increase in a serum creatinine to a level of at least 2.5 within 2 weeks, or representing more of an acute process, versus type 2, where we saw more of a gradual progression of serum creatinine from 1.5 to 2.5. Again, fast forward to 2019, where instead we used the terms HRS-AKI and HRS-CKD, specifically honing in on the serum creatinine cutoff. For HRS-AKI, the definitions have now changed to say that this is an increase in serum creatinine of at least 0.3 from baseline within 48 hours, or at least 50% increase within the past 7 days. So the take home here is that, HRS-AKI has mainly replaced this type 1 HRS term, whereas HRS-CKD has now replaced this type 2 HRS term. I will say too that, with these old definitions, they didn't necessarily take into account baseline serum creatinine. And for that reason, they had a little bit higher thresholds that could have led to later diagnosis. Whereas in our new definitions, we see the baseline serum creatinine taken into account. And this can be helpful because it also helps to call out patients that have normal serum creatinine levels, but overall decreased renal function. For example, maybe some of our older patients or some women who see lower levels of serum creatinine. Okay, so why is this important? Well, as you can see, HRS-AKI is a relatively new term. That being said, even though terlipressin is new to us in the US, previous trials studying terlipressin utilize this type 1 HRS definition. Since we know that the new HRS definition is actually less strict than the old type 1 HRS definition, this begs the question if these results of the previous trials actually still apply to patients who would be diagnosed with a less severe form of HRS-AKI. All right, I know that those definitions can be a little bit hard to wrap your head around. So just in summary, the two main forms of HRS in current day are HRS-AKI and HRS-CKD. HRS-AKI has predominantly replaced type 1 HRS, which is the old definition, and that represents an acute kidney injury process. Comparing this to HRS-CKD, which has predominantly replaced type 2 HRS, which is the old definition, which represents more of a progressive kidney injury. The focus of this presentation is going to be on HRS-AKI. All right, so thinking about the specific diagnostic criteria for HRS-AKI, on this slide here, I have called out the diagnostic criteria according to the American Association for the Study of Liver Diseases 2021 guideline. I will say that depending on what guideline you look at, there will be slightly different criteria in terms of how we would diagnose HRS-AKI. But according to the AASLD guidelines, diagnosis criteria includes cirrhosis with ascites, increase in serum creatinine, and that's defined as at least 0.3 increase in serum creatinine from baseline within 48 hours, or at least a 50% increase within the past 7 days. These patients have no response to diuretic withdrawal and albumin therapy, which is defined as 2 consecutive days of no diuretics and plasma volume expansion with albumin. These patients can't have shock or structural signs of kidney injury or recent use of nephrotoxic agents, which makes sense since we know that the diagnosis of HRS-AKI is a diagnosis of exclusion. And I did just want to call out here too that one of the other major guidelines we'll talk about a little bit later are the ECG guidelines, and they actually have different definitions based on the different stages of AKI. So that's an example of how you might see this specific diagnostic criteria change or differ a little bit depending on the guideline. Okay, getting into the pathophysiology of HRS. In basic terms, the two hallmarks of HRS pathophysiology are splanchnic vasodilation and renal vasoconstriction. And as a reminder for us all, splanchnic vasculature is the vasculature that leads to our stomach, intestines, spleen, liver, and pancreas. All right, so getting into a little bit more detail surrounding HRS pathophysiology, I'll first start out by saying that the pathophysiology of HRS is complex. And so this slide is meant to provide a summary of what the pathophysiology all entails. Starting at the top here, initially, these patients with liver disease and end-stage liver disease with cirrhosis have advanced cirrhosis, and this causes extra pressure on their portal system, which in turn causes increased portal hypertension. Our body sees this portal hypertension and tries to compensate by releasing NO, or nitric oxide. And in doing so, the nitric oxide does lead to splanchnic vasodilation, but also leads to overall decreased peripheral vascular resistance, which leads to overall reduced circulatory volume. And this is where we can see in these patients them having hypoalbuminemia. From here, when our body sees this reduced circulatory volume, like in many other disease states, RAS is stimulated and the sympathetic nervous system is stimulated to try and compensate. And for a moment, the cardiac output of the heart probably does compensate and is able to, but after not too long, the heart cannot compensate, and this is where we see this cirrhotic cardiomyopathy that can occur in these patients with liver disease and HRS. As RAS is stimulated, we know that we're going to see renal vasoconstriction, we're going to see sodium retention, but the splanchnic vasculature stays vasodilated due to the local effects of nitric oxide that's being released there. With sodium retention, we can see worsening ascites, and then this essentially just gets us back to the beginning cycle here of worsening portal hypertension. So the patient kind of gets stuck in this bad loop of worsening HRS. Okay, so thinking about HRS treatment, if HRS is suspected, what type of treatment would we use? So in general, first, again, we want to make sure that it is HRS. And so the first step is to rule out other causes. So we would always remove other nephrotoxic agents. We would treat any reversible causes of AKI like hypovolemia. And for that reason, volume resuscitation is actually recommended as a trial run of anywhere from 24 to 48 hours in any patient who is either hypovolemic or euvolemic. After that patient, we would consider pharmacologic treatment in these patients, which we will talk a little bit more about in the next slide. But you might also see patients who might be candidates for renal replacement therapy with HRS. And I do say this with caution because renal replacement therapy in these patients is controversial based on the literature. And one reason for that is that we see higher rates of mortality in patients who receive a liver transplant who also receive renal replacement therapy. Renal replacement therapy, the idea is that it's used as a bridge to transplant, but that's a significant outcome to consider since liver transplant is the only definitive treatment for these patients with HRS. Speaking of transplant, depending on the extent of their HRS, these patients may just require a liver transplant, but if their HRS has lasted a long time or was severe and they now have permanent damage to their kidneys, they may be candidates for a dual liver and kidney transplant as well. Okay, thinking about pharmacologic therapy, in general, the mainstay of therapy is vasoconstrictor plus albumin. We're using the albumin to try and increase the effective arterial blood volume, and we're using vasoconstrictors to not only try and decrease this splanchnic vasodilation that is kind of the initial contributor to this vicious cycle of HRS pathophysiology, but also to try and perfuse the organs appropriately. When considering different types of vasoconstrictors, the first one that we could use is terlipressin, which as you might as you might guess from the title of this presentation, we're going to jump into a little bit more detail about later. But terlipressin is a vasopressin receptor agonist, and this is going to act within the portal system. We could use norepinephrine, which is an alpha-beta agonist. Norepinephrine is going to act on the heart to increase cardiac output, but also act in the periphery to try and increase the peripheral vascular resistance. And then the last most common one is octreotide plus midodrine. Octreotide being a somatostatin agonist that also is going to act within the splanchnic vasculature to cause splanchnic vasoconstriction, whereas midodrine is an alpha agonist and again is going to work in the periphery to try and increase our peripheral vascular resistance. One important point here is that the administration of norepinephrine requires continuous monitoring, and for that reason, in order to use it, patients must be at an elevated level of care or within an ICU, which, here at UW Health, we have an ICU, but this certainly is an important consideration for smaller hospitals that don't necessarily have this type of care readily available at their institution. Okay, let's talk a little bit about treatment that's not recommended generally for HRS. And the first one being therapeutic paracentesis. Generally, this isn't recommended due to the risk of actually having volume depletion and worsening kidney injury. And the second treatment that isn't recommended usually is this TIPS procedure, or transjugular intrahepatic portosystemic shunting. This is a picture of the TIPS procedure on the right here, and essentially a stent is placed connecting the portal vein to other adjacent veins to try and help reduce some of the portal hypertension. You will see TIPS procedures used in some patients, like renal replacement therapy. The TIPS procedure can be used as an argument to help bridge a patient to transplant, but overall, the evidence behind the TIPS procedure in this population of patients is not very strong. All right, so this brings us to our first knowledge check question. Which of the following accurately describes the pathophysiology of HRS-AKI? Is it A, splanchnic vasodilation, B, renal vasodilation, C, increased circulatory volume, or D, portal hypotension? And I'll have you throw your answers in the chat. Okay, I'm seeing a lot of A's come through, and that's right. So in the pathophysiology of HRS, we see splanchnic vasodilation, we see renal vasoconstriction, we see decreased circulatory volume, and portal hypertension. All right, next let's jump into a review of some of the guidelines that discuss HRS and the treatment for HRS. Overall, we're going to be touching on the 2018 AASL guidelines, the 2020 SCCM guidelines, the 2021 AASLD guidelines, and then last but not least, the 2022 ACG guidelines. Starting with the 2018 EASL guidelines, they recommend that vasoconstrictors and albumin are recommended in all patients with HRS-AKI with a stage greater than 1A. Now, in terms of what stage 1A is or what that means, on the right you'll see a table with how they categorize AKI. And they essentially use a modified ICA AKI criteria. And you can see that when looking at 1A versus 1B, stage 1 includes an increase in serum creatinine of at least 0.3 from baseline, or 1.5 to 2-fold from baseline. But 1A, these patients have a serum creatinine of less than 1.5, whereas for 1B, these patients have a serum creatinine greater than 1.5. The EASL guidelines recommend terlipressin plus albumin as a first-line agent combination. They also call out that norepinephrine may be used as an alternative to terlipressin, and that midodrine plus octreotide may be used if both norepinephrine and terlipressin are unavailable. Moving on to the 2020 SCCM guidelines, they recommend using vasopressors over not using vasopressors in critically ill patients with ACLF or acute on chronic liver failure and HRS. They also call out that there's insufficient evidence to recommend one vasopressor over another. And again, the vasopressors that they're referring to are terlipressin, norepinephrine, and then midodrine plus octreotide. And lastly, they call out that combination albumin plus vasoconstrictors does remain to be a common intervention in these patients in the absence of liver transplant. Okay, next up, we have the 2021 AASLD guidelines. They call out the treatment of choice in these patients, including vasoconstrictors in combination with albumin. Again, they call out that terlipressin is the preferred vasoconstrictor. And if terlipressin is not available, norepinephrine may be used as an alternative. If both terlipressin and norepinephrine are not available, then midodrine plus octreotide may be used as an alternative. Okay, last but not least, moving to the 2022 ACG guidelines, they call out that vasoconstrictors plus albumin are recommended over albumin alone in patients with stage 2 and stage 3 AKI, but make no recommendation for the use of vasoconstrictors in stage 1 AKI. And again, on the right, I've included how they define AKI. And you can see that for stage 1, where they make no recommendation of which vasoconstrictors or if we should be using vasoconstrictors, that criteria is an increase in 0.3 within 48 hours, or an increase in 1.5 to 2 times from baseline serum creatinine. They also say that hospitalized patients with HRS-AKI without high-grade ACLF or major cardiopulmonary or vascular disease, we can use terlipressin or norepinephrine. Okay, so as we can see, multiple guidelines touch on using vasoconstrictor agents for HRS, and we now know that some guidelines actually recommend terlipressin first line. So from here, let's jump into terlipressin itself and learn more about it. Terlipressin is indicated to improve kidney function in adults with hepatorenal syndrome with rapid reduction in kidney function. The package insert does call out that patients with a serum creatinine greater than 5 are unlikely to benefit. Terlipressin is the first FDA-approved drug for HRS-AKI, and as some of us might know, terlipressin is a newly FDA-approved drug within the US, but it's actually been used around the globe for much longer and has widespread use. Thinking about the mechanism of action for terlipressin, it is a synthetic vasopressin analog and is actually a prohormone of lysine vasopressin. It acts on both V1 and V2 receptors, but for the purposes of HRS-AKI, we mainly care about the V1 receptors as they're located within the splanchnic vasculature, and stimulation of this receptor causes selective splanchnic extrarenal vasoconstriction, which in turn results in decreased splanchnic blood flow and helps to reduce portal hypertension. So essentially with this splanchnic vasoconstriction, this helps to reset the hemodynamics that we see in HRS pathophysiology, and in turn decreases portal hypertension, helps to increase perfusion to the kidneys, which in turn will increase our effective arterial volume and overall help to reduce this RAS compensation that our body is trying to use to help the situation. All right, this slide calls out the dosing that is provided in terlipressin's package insert. It says Terlivaz because that is the brand name for terlipressin. As you can see with the box on the right, on days 1 through 3, the initial dose is 0.5 milligrams every 6 hours, and it's important to have a baseline serum creatinine recorded on day 1. In this case, baseline serum creatinine is defined as the last available serum creatinine before treatment initiation. On day 4, the dosing recommends to reassess serum creatinine, and based on what the serum creatinine does, determines what we would next do with the dose. So if the serum creatinine has decreased by 30% or more, we're going to continue the current dose. If the serum creatinine has decreased by less than 30% from baseline, we're going to increase the dose to 1.7 milligrams every 6 hours. And if the serum creatinine is at baseline or actually above baseline, the drug isn't thought to be working and it should be discontinued. After dosing is reassessed on day 4, it should be continued until 24 hours after the patient achieves a second consecutive serum creatinine less than 1.5, or for a maximum of 14 days. Terlipressin is given IV, and it can be given peripheral or through a central line. And since it does have this pro-hormone mechanism, that's why we can give it intermittently, opposed to a continuous infusion. Less than 1% of terlipressin is excreted in the urine, and for this reason, we don't have any renal dose adjustments. All right, terlipressin does have a couple black box warnings, those being the first one for serious or fatal respiratory failure. The package insert calls out that patients with volume overload or ACLF grade 3 are at increased risk for this respiratory failure. And for this reason, we should be monitoring patients' oxygen saturation before drug initiation. Like HRS and AKI, ACLF also has different definitions or specific criteria depending on where you look. But in general, ACLF grade is used to determine the extent of organ failure that a patient has. And when it says ACLF grade 3, that's typically thought of a patient having at least 3 different types of organ failures from different systems involved. The second black box warning states do not initiate terlipressin if the patient is experiencing hypoxia, which is defined as an oxygen saturation of less than 90%, and it shouldn't be used until this oxygenation improves. For this reason, we should be monitoring patients for hypoxia using a continuous pulse ox during their treatment, and we should be discontinuing treatment if their oxygen saturation does dip below 90%. Okay, a little bit more on the safety surrounding terlipressin. Terlipressin is contraindicated in patients experiencing hypoxia or worsening respiratory symptoms, which aligns with the black box warnings. Terlipressin is also contraindicated in patients with ongoing coronary, peripheral, or mesenteric ischemia. Terlipressin has warnings for ineligibility of liver transplant, especially when patients have a MELD score of at least 35. This is a significant consideration, as we know that the only definitive treatment for patients with HRS is liver transplant. Terlipressin also has warnings for serious or fatal respiratory failure, ischemic events, and embryo-fetal toxicity. The most common adverse reactions to terlipressin include abdominal pain, nausea, diarrhea, dyspnea, and respiratory failure. All right, jumping into our second knowledge check question, I'll read this case out loud. ZZ is a 48-year-old female with past medical history significant for alcohol-induced cirrhosis who was admitted to general care with recurrent ascites. ZZ appears hypovolemic and is initiated on albumin 1 gram per kilo per day. Pertinent labs for ZZ include a serum creatinine of 1.4. Her baseline is known to be 1.2. Her current oxygen saturation is 92% on room air, and her MELD score was calculated to be 20. Fast forward to 72 hours later, ZZ's serum creatinine is now 2.8, but ZZ is otherwise stable. ZZ appears euvolemic on exam and is afebrile. What therapy would be most appropriate for ZZ at this time? Is it A, continue albumin and initiate terlipressin? B, continue albumin and initiate midodrine plus octreotide? C, continue albumin and initiate norepinephrine? Or D, continue albumin and initiate furosemide? Feel free to throw your answers in the chat once you wrap your head around the case. All right, I'm seeing some A's come across the top of my screen, and that's right. So just piecing through some of the answers here, We see that ZZ serum creatinine has doubled within 72 hours, which does meet the serum creatinine cutoff for HRS-AKI. We want to think about reversible causes first, but with the information provided in the case, we have no reason to believe that ZZ is on any other nephrotoxic agents, and we have no reason to believe that ZZ is in shock, as she's euvolemic and afebrile. We're not suspecting any infection or septic shock. ZZ has been trialed on volume resuscitation with albumin after 72 hours and still has not responded to therapy. Of note, albumin and norepinephrine could be an option here, but as it stands, this patient is in general care and would require a higher level of monitoring in order to receive norepinephrine. And after reviewing the guidelines, we can see that in some guidelines, terlipressin is recommended first line, and we have no contraindications to terlipressin. This patient has no known ischemia. The MELD score is less than 35. She's saturating on room air at 92%, and she's euvolemic, so we wouldn't suspect her to have any pulmonary edema or be at extra risk of respiratory failure. All right, so I did want to provide an overview of how terlipressin was approved in the US. And actually this journey starts over 10 years ago after the first approval was submitted after the OT 0401 trial. And in this trial, terlipressin was compared to placebo and HRS, and essentially there was no statistical difference seen in HRS survival, HRS reversal, or survival. After this 2008 trial, the reverse trial was actually completed in 2016. Again, looked at terlipressin versus placebo and HRS, and again, saw no statistical difference in HRS reversal or survival. After the reverse trial results were published, the FDA issued a complete response letter, which essentially means that the FDA denied terlipressin being approved. After this first complete response letter, the CONFIRM trial was designed, and it was actually designed in collaboration with the FDA. Now, as we'll find out, the CONFIRM trial is what ultimately led to terlipressin being approved. So we'll look into the CONFIRM trial a little bit deeper in a few slides. But after the initial CONFIRM trial results came out, the FDA issued a second complete response letter, given the outcomes of the CONFIRM trial weren't very strong. At this point, a post hoc analysis was completed using the CONFIRM trial. We saw a little bit different outcomes, and ultimately, the FDA approved terlipressin using the post hoc analysis results of the CONFIRM trial. Of note, I do want to call out that these are the three trials that looked at terlipressin versus placebo that were conducted in the US. Outside of these trials, there are many trials that look at terlipressin, but they were not completed in North America and did not include American patients. And for that reason, were not included or considered by the FDA when considering terlipressin's approval. All right, so let's get back to the CONFIRM trial, since we know that this was the phase 3 trial that served as the basis for FDA approval of terlipressin in the US. So the CONFIRM trial was a phase 3 randomized double-blind placebo-controlled trial. It looked at 300 patients with HRS-1 or type 1 HRS. It excluded patients with a serum creatinine greater than 7, patients with large paracentesis within the last 2 days, or patients who had the presence of sepsis or infection. Patients were randomized 2-to-1 to receive terlipressin or placebo, and they received 1 milligram every 5.5 to 6.5 hours. There was no official protocol for these patients to receive albumin, but it was strongly preferred that both groups receive albumin at 1 gram per kilo on day 1, followed by 20 and 40 grams a day thereafter. The primary endpoint was verified reversal of HRS, and this was defined as 2 consecutive serum creatinine values less than 1.5, 2 hours apart by day 14. They also had to have survival without renal replacement therapy for at least 10 days after their treatment was completed. In terms of safety, abdominal pain, nausea, diarrhea, hepatic encephalopathy, and dyspnea were the most common side effects seen. And 12% of patients in the terlipressin group discontinued therapy due to a side effect, compared to 5% in the placebo group. Death within 24 hours of discontinuing therapy occurred in 4% of the terlipressin group compared to 1% of the placebo group, and respiratory failure was the most common cause of this. In general, respiratory failure was seen in 14% of patients in the terlipressin group and 5% of patients in the placebo group. Ultimately, 32% of patients in the terlipressin group achieved the primary outcome of verified HRS reversal compared to 17% in the placebo group, and this was a statistically significant outcome. All right, so looking at a couple of the other secondary endpoints assessed in the CONFIRM trial, we do see that less patients underwent liver transplant in the terlipressin group at day 14 and day 90. And again, this is significant to consider since we know that liver transplant is the only definitive treatment for these patients. We also saw that more patients died in the terlipressin group at days 14 and 90 compared to placebo. So if you're thinking that those results don't seem the greatest, that's exactly what the FDA was thinking too. And at this point, they had rejected the approval. The CONFIRM post-hoc analysis was done next. And in the post-hoc analysis, they excluded patients at highest risk of respiratory failure. So they excluded patients that had ACLF grade 3, had a serum creatinine greater than 5, or were transplant listed with a MELD score of at least 35. Again, in the post-hoc analysis, HRS reversal was more common with terlipressin compared to placebo, and this still was statistically significant. The difference with the post-hoc analysis is that fatal respiratory failure, although still more common with terlipressin, had actually decreased from the initial analysis. The fatal respiratory failure decreased from 14% in the overall sample to now 10% in the post-hoc analysis with terlipressin. All-cause mortality was similar between groups in the post-hoc analysis. So at this point, because of the decreased fatal respiratory failure seen in the post-hoc analysis, the FDA ultimately approved the use of terlipressin. Some key discussion points I think are important to recognize are that the inclusion criteria for this trial used HRS-1 or HRS type 1. And as we mentioned before, that's different from the current definition of HRS-AKI that we would currently use. The trial showed that terlipressin did improve kidney function outcomes by day 14. We also saw higher incidence of adverse effects in the terlipressin group. More patients in the terlipressin group died at day 14 and day 90, although the study was not powered to assess survival between groups. Less patients in the terlipressin group received liver transplant, and we do know that at baseline, both patients in the terlipressin and placebo group had similar MELD scores, although the MELD scores at time of transplant weren't recollected. So it's unclear if terlipressin, had an effect in changing the MELD score. In conclusion, terlipressin plus albumin is more effective than placebo in reversing HRS, but is associated with serious adverse effects, including respiratory failure. And that was the conclusion from this CONFIRM trial. Okay, I did want to mention just a couple of other more recent meta-analyses that have looked at patients with HRS and the use of terlipressin. The first being this Petrie network meta-analysis that was conducted in 2022. And this included 26 randomized controlled trials looking at over 1,700 patients. And this network meta-analysis did include the CONFIRM, REVERSE, and OT-0401 trials, which were the 3 trials of terlipressin versus placebo that were completed in the US. This network meta-analysis included patients hospitalized with HRS-1 or HRS-2, and they could be treated with any pharmacologic agent. The main endpoints of the study were all-cause mortality, HRS reversal, and serious adverse effects. All right, so since this was a network meta-analysis, that meant that the authors looked at both direct and indirect comparisons. Since this is a network meta-analysis, the results are reported a little bit differently than what we might expect in a regular meta-analysis. So I'll take a minute to just describe what we're looking at on this slide. To start on the right, results are reported as drug versus placebo as absolute risk difference per 1,000 patients. So, for example, under terlipressin and reversal, 142 means that terlipressin achieved 142 more reversals compared to placebo per 1,000 patients. Below each number, you'll see high, low, or very low reported. And this was how the authors reported certainty of evidence using the network meta-analysis grading criteria. This takes into account risk of bias, inconsistency, publication bias, and not only if the results of the individual trials were statistically significant, but also if the thresholds that they used in determining significance were appropriate. The standardized language of high, low, very low means the following. High means that drug X reduces mortality, for example. Whereas if we saw moderate, which isn't actually included in this scale or in these results, we would think that drug X probably reduces mortality. For low certainty, we would think that drug X may reduce mortality, and for very low certainty, we would say that the evidence of drug X on mortality is very uncertain. So that gives you a little bit more insight as to what these evidence levels mean and how the authors reported them. So the take home from these two tables, starting with the table on the right, looking at direct and indirect comparisons. And again, this is looking at drugs versus placebo. We see that terlipressin had higher rates of HRS reversal, and this was the only outcome with high certainty. Terlipressin also saw less mortality than compared to placebo than norepinephrine and midodrine plus octreotide. In terlipressin, we did see more adverse effects compared to norepinephrine, but less than midodrine plus octreotide. And I do also want to call out that of concern, actually in this study, they found that midodrine plus octreotide saw more mortality than placebo. So the take home here is that terlipressin had the only high evidence in reversing HRS-AKI. Next, moving to the direct comparisons, we can see that terlipressin was compared to midodrine plus octreotide and also compared to norepinephrine. In all of these results, we see that terlipressin had higher rates of HRS reversal and lower rates of mortality. That being said, all of these outcomes had low certainty of evidence. And for that reason, you could argue that these comparisons are not significant. So in conclusion, the data from this network meta-analysis shows that terlipressin increases HRS reversal compared to placebo and may reduce mortality. The results also show that norepinephrine may improve HRS reversal and may be more appropriate than octreotide plus midodrine. Since this is a network meta-analysis, we have the advantage of including more studies, but that also means that these studies were more heterogeneous in nature. And for that reason, the study definitely has risk of bias, although that is reflected in the certainty of evidence. Again, I want to call out that this trial utilizes the type 1 HRS definition, which is not how we currently would describe HRS-AKI. And the majority of the outcomes here were all low or very low level of evidence. All right, the last meta-analysis that I wanted to touch on was a meta-analysis conducted by Wang and others in 2018. And this was a systematic review with meta-analysis that looked at 18 randomized controlled trials, including over 1,000 patients. And this included just the reverse and OT 0401 trial. This meta-analysis looked at HRS-1, defined as 100% increase in serum creatinine greater than 2.5 within 2 weeks, and also looked at patients with HRS-2. These patients could be receiving terlipressin plus or minus albumin versus placebo or any other vasoconstrictor. And again, the main points of this meta-analysis were HRS reversal, mortality, and safety. Looking at the results of this meta-analysis, we see that when compared to placebo, terlipressin had higher rates of HRS reversal and lower rates of mortality, and these were both statistically significant results. Comparing this to terlipressin versus norepinephrine, there was actually no statistically significant results in terms of HRS reversal or mortality. Terlipressin was shown to have increased rates of adverse effects compared to norepinephrine, and this was statistically significant. Of note, only one trial assessed terlipressin directly to midodrine plus octreotide, and the trial did find that terlipressin had higher rates of reversal of renal failure, and this was statistically significant. So in summary, these results can show us that terlipressin was superior to placebo and octreotide plus midodrine for reversal of HRS and improving renal function, but did not have superiority when compared directly to norepinephrine. And I do want to call out too, the evidence behind terlipressin versus midodrine plus octreotide here is weaker, since we only had one trial that actually compared these two agents included in the meta-analysis. All right, getting to our last knowledge check question. Which of the following would not exclude the use of terlipressin based on safety parameters? Is it A, mechanical ventilation, B, pulmonary edema, C, hypoalbuminemia, or D, a MELD score of 37? Feel free to throw your answers in the chat. All right, I think I saw some C's come through, which is the correct answer. So we know that terlipressin is contraindicated in patients experiencing hypoxia. And obviously, if a patient is mechanically ventilated, they're not saturating on room air at least 90%. We also know that terlipressin has black box warnings and warnings for developing respiratory failure, and this is especially seen in patients who have signs of volume overload. So if someone has pulmonary edema, that would not make them a good candidate. And lastly, we know that there's also a warning for ineligibility of liver transplant seen in patients with a MELD score of at least 35. And so at a MELD score of 37, that would also not make the patient a good candidate. As a reminder, patients with HRS-AKI have reduced overall circulatory volume. And so in these patients, we would see hypoalbuminemia, which is one reason why we use albumin as our agent in volume resuscitation. Okay, before we wrap up, I did just want to call out that terlipressin, since being approved, was added to formulary at UW Health here. And it was added to formulary with the following restrictions. Those being that it must be authorized by gastroenterology and hepatology. The patient must have HRS-AKI, defined as the AASLD 2021 guidelines, which were the same diagnostic criteria that I presented earlier in the presentation. Terlipressin should not be used if a serum creatinine is greater than 5, the patient has ischemic cardiovascular disease, hypoxia, ACLF grade 3, or a MELD score of at least 35. And all of those parameters reflect either black box warnings or patients that were actually excluded from the CONFIRM trial with greater risks of respiratory failure. And then per the dosing recommendations in the package insert, terlipressin use must be reevaluated at day 4 and should not exceed 14 days total therapy. All right, in conclusion, I hope you can take away that the pathophysiology of HRS is multifactorial and complex. Terlipressin is the recommended first-line agent for HRS-AKI by European and US guidelines. And we have evidence that supports HRS reversal with terlipressin. However, studies supporting longer-term outcomes like mortality benefit are lacking. There are significant safety concerns surrounding the use of terlipressin, and these include respiratory failure, ischemic events, and ineligibility for liver transplant. We need more head-to-head studies in order to further describe the benefit of vasoconstrictors compared to each other. And lastly, the recent meta-analysis by Wang and others did not provide significant evidence favoring terlipressin over other vasoconstrictors. And that is all I have for you. Happy to answer any questions. Thank you.